Nilesh,
Yes, ma'am.
chairperson introduction 119, huh?
Yeah.
Let's give a importance to academics. मैंने बहुत सारे students को भेजा है.
Amit, tell me whenever we are live, we can start.
Technical support team.
Yeah, we can start in
Yes, we start.
3, 2, 1. We are live, sir. We can start. Thank you.
A very good evening. I welcome you all to this evening session of POGS Pearls, Unraveling the Mystery with Pearls of Wisdom, with none other than the stalwarts and experts in the field. We all know that pearls are this moti, but to weave that motis together, to weave that pearls together, we require a string. इसी बात पे एक शुरुआत में एक शेर अर्ज करता हूं. वो धागा ही था जिसने छिपकर पूरा जीवन मोतियों को दे दिया. वो धागा ही था जिसने छिपकर पूरा जीवन मोतियों को दे दिया और ये मोती अपनी तारीफ पर इतराते रहे उम्र भर. So we are just like this pearls, but we have this string which has roped us together, all the POGS members together, and who is organizing these wonderful programs throughout a tenure. Dr. Sunita Tandurkar, President POGS. I welcome her. And at the start of this program, I would ask her to give her presidential remarks.
Hi, Nilesh. Thank you so much. Thank you for your kind words and dialogues. You always amaze me with something different out of the box thinking. Thank you, the entire team of Sun for this beautiful academic program, and Dr. Jaideep Tang, who never has no word in his dictionary. So thank you, Jaideep, for accepting this invitation. I know you are very busy, not only in your private life, but I'm also aware that you are going for a Foxy elections, and naturally you are busy visiting all the societies, and you should, because you have visited in last 20 years these societies physically many more times, and it is wonderful for people to meet you again and again, and I'm sure you will have such a rocking Foxy year that we all will celebrate together physically. Dr. Vaishali Kodenai, the professor who always is smiling, and she was not even aware that I told Nilesh to put up her name there. She was surprised. She said, "Ye mera naam kab aa gaya?" I said, "Do we need your permission?" She is always there for us. Dr. Anand Balera, our past president POGS, during your presidency, we learned a lot things from you, including the way we should be disciplined, we should be focused on academics, and ensuring that the interest of the delegate always should be our top priority. Preeti, as a chairperson of Safe Motherhood Committee, I worked with you a couple of weeks ago, and I realized I was watching you. I had visited to your place. You had really taken such a good care of all of us together. It was Reshma, me, Jaideep, and Nandita together on a UP tour for my VP elections. But that time I thought because we have reached to your place, you were taking care. But after AICOG Lucknow and during your this, we saw the leadership quality in you. Kalyan, thank you for accepting. Pune is always second home for you. At least for me, Kalyan is a home member because he has worked with me in IAG as a managing committee member, and he worked tremendously. Whenever I said, Kalyan, you have to do this, he always said, yes, ma'am, we do it. So keep this nature for doing the things for others is very important. And Faisi, all the way coming from South India, I'm very happy that you accepted this invitation and you are being there. Pregnancy, infections, vaccinations, all this is such an important topic. And when Nilesh said me, we would like to have this discussion, I said Jaideep Tang is the only person I feel about. It's not only the COVID vaccination, but he has involved in so many guidelines and so many things about FOXY that I felt he will be the right person who is representing SAFOG. I mean, AOFOG, I'm very sorry, you will kill me. AOFOG, all you know the Asian, what are our infections. You always are close with the RCOG team, FIGO team. So, Jaideep, thank you for accepting this topic as well. I know you must have spoken on so many subjects and you have to re-prepare a talk. It's a great effort, and I'm sure you are working very hard for making your talks the best memorable talk ever in every webinar. You mesmerize us. Thank you for accepting an invitation. And Nilesh, you can proceed.
Thank you, ma'am. Thank you for those blessings and inaugurating this today's CME of POGS Pulse. I would now like the Team Sun to display the CVs of the chairpersons. We have eminent chairpersons and eminent faculty for this program. It's always said that don't stop when you are tired, stop when you are done. And I think most of the faculties and most of the personalities present here do represent this. So we have the chairperson for the first session, Dr. Sunita Tandurkar, President, Pune Gynec Society. We have Dr. Anand Bhalerao, sir, who is the past president of Pune Gynec Society and a teacher for more than 40 years in undergraduate and postgraduate teaching in the BJ Medical College of Pune. We have none other than Dr. Preeti Kumar, who is the chairperson of Safe Motherhood Committee, and such a short introduction won't suit her. She has n number of credentials to her credit, and she is organizing such wonderful programs at national and international level. Welcome, madam. I welcome all the chairpersons, and I request Sunita madam to kindly introduce Jaideep Tang, sir.
Since Dr. Bhalerav has joined, we can have Dr. Bhalerav introducing Jaideep.
Can we have the CV, please?
CV, please?
Hello.
Yes, Dr. Bhalerav.
I think Jaideep is a very seasonal speaker as far as the POGS is concerned. So I really don't think if he needs any introduction in the society like Pune Obstetrics and Gynec Society. And we know him personally and we have seen his work, academics, as well as the actual practical work. At present, he's working as a Secretary General, Federation of OBGY, All India POXY. He is immediate past president, Mumbai OBGYN Society, and he is the chair, International Federation of Obstetrics and Gynecological Safe Abortions, Deputy Secretary, Asia Oceania Federation of Obstetrics and Gynae, awarded the FRCOG honors in cause in 2020 by the Royal College of Obstetricians and Gynecologists to be conferred in September 2021.
This is so very important award, sir, which RCOG teams gives to the person from India.
Right.
Gynecologist. And in this year 2020, Dr. Jaideep Tang has been awarded this very prestigious position by Royal College of Obstetrician and Gynecologist. And as a president of Mumbai OBGYN Society, the dynamic work what he has done, we all have seen, sir.
Right. Okay. So, Sunita, can we go ahead? Can we request Jaideep to please start his session?
Yes.
Okay. Jaideep.
Thank you. Thank you very much, sir, for that very, very kind and generous introduction. So, right. So let me ask the two most famous questions since the lockdown began. Are my slides seen and am I audible?
Yeah.
Yes.
I was just telling Sunita and Nilesh and Vaishali before we started that this is actually my 700th webinar since the lockdown began. And, I started counting it after last year, May. And I think it's been quite an experience. And it's really amazing, isn't it? I mean, Sunita was just mentioning about all the travels that she's had to do in her long journey in what will ultimately culminate as her being the president of our premier organization. But it's a dramatic change. Today, this is the fourth webinar I'm speaking in. I spoke to a group of NGOs from Delhi in the morning, and then I spoke to two other societies, and this is my fourth webinar today. So it's really quite amazing what technology has done. Let me first begin by thanking Sunita for inviting me and saying such nice things about me. Sunita, I wish I would have known. I would have told my wife to log in for the webinar. Then she could have at least heard somebody saying such nice things about me.
This is recorded.
And of course,
I will send you the clip.
and of course, Dr. Anand also. Let me also acknowledge Vaishali and Nilesh. Again, I've known both of them since many years. It's always a pleasure to interact with them. And then the chairpersons, you picked some of my closest friends. Preeti is there, Dilip, Fesi and Kalyan, and I look forward to their inputs and comments at the end. Saying no for the Pune Society, Sunita, Nilesh and Vaishali is simply not an option for me. There is no question that whatever the Pune Society needs, it is going to get as far as I am concerned. Let me start this presentation by first focusing a little bit on the history of vaccination. So the way I've structured this presentation is we'll talk a little bit about history. We'll talk a little bit about the general well-known vaccinations in pregnancy. The next section of the talk will cover COVID-19 vaccination, but within that, we will talk a little bit about COVID-19 and infections and death rates in general. And then we will round up the whole presentation by talking about COVID-19 vaccine first in general, and then as it relates to pregnancy and lactation, which is what concerns us mostly. Vaccination is not something which is new. I mean, if you look at Ayurvedic literature, if you look at ancient Egyptian and even Greek literature, there are instances of vaccines, although they were not called vaccines at that time, being used even in ancient times to sensitize the body to that disease. You have that famous saying in Hindi, "Loha lohe ko kaatta hai," and I probably think it comes somewhere from that. However, the biggest medical achievement or the biggest public health achievement ever in the history of the world is when the World Health Assembly officially declared smallpox eradicated. And I think this is such a remarkable feat of science, and it was purely because of vaccination. There are now 12 childhood diseases which are preventable by vaccination. I'm not going to go through the list, but you can look at that wide variety of diseases which can be prevented by vaccination, starting from varicella, mumps and tetanus, right up to hemophilus influenza, and hepatitis, and so on. The question is, why should obstetricians and gynecologists talk about vaccines? Traditionally, vaccines have been seen as the domain of pediatricians. In my house, everything is the domain of pediatricians because I'm married to a pediatrician. But at least for this vaccination, there is a thought, why should obstetricians be worried about vaccination? We should be worried about vaccination because vaccination is an opportunity to protect women by building up active immunity and neonates and infants by the transfer of passive immunity. Remember that pregnant women are already most of the time going to healthcare workers, doctors, midwives, ashas, and in a sense, they are already in the health system. And because they are already in the health system, this should be seen as a golden opportunity to take them into the net of vaccination and prevent all those diseases that we talked about in the previous slide. It is also true that as obstetricians and gynecologists, women are with us for almost the entire duration of the pregnancy. And when they are there with us for such a long time, acceptance is very high when we recommend the vaccines. Nilesh, will you please tell me when I'm 5 minutes short of my time? You've given a very generous 30 minutes, but still.
Yeah.
Yeah.
Sure.
I've timed it, but just in case. Yeah.
Yeah, sure.
So let us start with one of the first vaccines that was recommended in pregnancy, and it was 2 doses of tetanus toxoid from the second trimester, 28 days apart, which was the first vaccine which was actually used routine in pregnancy. The perspective of using tetanus toxoid at that time was that natural disasters and war increase the risk of tetanus. Although tetanus is rare, when it does occur, it is lethal. The vaccine for tetanus is safe, effective, and economical and leads to huge reductions in tetanus-related mortality. And that is how actually vaccination in pregnancy started. And this was what the national immunization schedule used to look like till not very many years back. TT1, TT2 booster, and then BCG for the infants. Slowly, over a period of time, new vaccines have come in. And, I always used to get very confused about the terminology of vaccines. As I have written over there, the alphabet soup of capital D, small d, T, P, and so on and so forth. So it's actually quite easy to understand. The bacterial diseases are grouped together: tetanus, diphtheria, and pertussis. The terminology is based on component, that means which disease. So, for example, D is diphtheria, T is tetanus. Quantity, and that quantity is relative to each other within that vaccine component. So if you have a higher amount of diphtheria, you'll have a capital D. If you have a higher amount of pertussis, you'll have a capital P. But remember, this is not an absolute quantity, it's in relation to each other. And whether it is whole or cellular, for example, for pertussis. So for children, you have diphtheria, tetanus, and whole pertussis vaccine, as you can see in the next sentence. You have DTaP and DT. And for adults, you have TD or DT, depending on what you want to call it. The T is capital, the D is small. And then you have TDAP. Again, notice the capital and the small, because again, in relation to each other, that's the dose. And A and P, and over here, the A stands for acellular, because we don't give whole vaccines or live vaccines in pregnancy at all. So that's how you understand the alphabet soup of TD, TD, TDAP, and so on and so forth. In fact, when we started using these vaccines in pregnancy, we had to be very careful to educate our staff, because, TD, TDAP, and all that is a little confusing. TT1, TT2 was very easy. But after all these kind of alphabet soup started coming in, we really had to tell our staff. In fact, we bought a separate fridge to store these vaccines so that there was no mistake. Previously, we used to store the TT injections along with all our HMG and HCG and everything. But once this large number of vaccines came, we had to actually buy a separate fridge. Why should we talk about a diphtheria vaccine? Because it's a misconception that diphtheria is a disease of infants and children only. In fact, in the last 2 decades, India has seen 4 major outbreaks with an annual mortality of 3,300. For example, in the 2016 Kerala outbreak, 79% of cases were in the more than 10 years age group. And therefore, it is imperative that a booster of diphtheria be given to adults. And these kind of thoughts actually led to the end of the tetanus toxoid era, and TD was the first vaccine which replaced tetanus toxoid. So as is saying here, TT was replaced with TD in UIP to limit the waning immunity against diphtheria in older age group. In fact, TD vaccine is to be administered to adolescents at 10 to 16 years, and the dose that we give in pregnancy actually acts as a booster to prevent subsequent diphtheria infection. For pertussis, the story is a little different, because you can't give the pertussis vaccine to children till, or you can give it, but it's not protective until the first 4 months of life. However, infants can get infected even before the first 4 months of life. In fact, more than 75% of pertussis deaths occur at less than 3 months, and about 25% of infants who get infected get pneumonia or encephalopathy. So the rationale of using pertussis vaccine in pregnancy is that infants, even before this 4 months period has passed, can be protected by passive immunity for the mother. And this has led to the global recommendations on Tdap, where practically each and every association of note, including FOXI, has recommended that Tdap should be administered in pregnancy in order to provide optimal protection to the baby. In this case, it's for the baby during its first months of life. The next vaccine is the influenza vaccine, but remember, you have to give the inactivated influenza vaccine. It's recommended to be given as a single dose. Nowadays, I've started telling patients this is the non-coronavirus influenza vaccine, because the minute they say influenza vaccine, they start thinking I'm giving them the COVID vaccine. So I'm making this distinction as far as the patients are concerned, to be very clear that I'm not giving them the COVID vaccine. It, of course, can be administered in epidemics, and this vaccine actually changes annually. You know, there is this big tradition which happens in spring and autumn in the US where people go to get their flu shots. And then that leads to a whole lot of selfies on the internet, and we will talk about selfies a little later. So we have so far understood about why diphtheria, why tetanus, why pertussis, but even influenza is equally important because pregnant women are in fact more susceptible to influenza. The likelihood of ARDS due to flu is higher in pregnancy, and most importantly, it confers protection to the newborn who are not to be vaccinated for this till the first 6 months of life. So these kind of thoughts have now led to the new standardized vaccination protocol in pregnancy. And this is a chart that we have put up at our reception. So whenever the patient comes in, she's already reading that and knows that she has to expect a vaccine at this time: 12 to 16 weeks TD, 20 to 24 weeks influenza, 28 to 32 weeks Tdap, and we give it 0.5 ml IM in the upper arm. I always have this argument with my wife. She insists that we should give it on the thigh, but our staff is used to giving it in the upper arm. We continue to do that, but I think we are slowly now, you know, one has to listen to one's wife. So we are now slowly transiting to giving it intramuscular on the thigh. If you look at the other chart in purple over there, that's a very comprehensive chart of which vaccines can theoretically be used in pregnancy and which vaccines can absolutely not be used in pregnancy. It's a little complicated. Just look at that simple little chart in black over there, which will tell you what is the current state of art for vaccination in pregnancy. So some frequently asked questions: what should be the duration between the two vaccines? Ideally 4 weeks. Why 4 weeks? Nobody exactly knows. It's perhaps to give time for the immunity, prevent cross reactions, etc. Does the season or time of the year affect the schedule? You can make seasonal variations for flu vaccine. When I say seasonal variations, if it is flu season, instead of giving the influenza dose in between, substitute your, instead of giving the TD first, give the influenza vaccine first, so that she's protected for the duration of the flu season. For late registration, can you give TD or Tdap with flu? Absolutely, because the principle in its sense is don't administer live attenuated vaccines together, and these vaccines are not that. So which are the vaccines which are contraindicated in pregnancy? I already made a reference to that. Live vaccines, MMR, varicella, BCG are contraindicated. And what do you do if a woman is unknowingly immunized with these or becomes pregnant within 3 months of immunization? It's a very important question, particularly because now some of us have the habit of doing a rubella test before as a part of pre-counseling. And if the rubella test is negative, IgG, IgM, then we say, take the rubella vaccine before you get pregnant. At that point in time, you have to tell the patient that if you are pregnant within the first 2 or 3 months after taking the rubella vaccine, there is a theoretical risk that you may have anomalies in the fetus and ultimately land up wanting an abortion. So you need to counsel them about theoretical risk. However, it's not an automatic indication for MTP, but it comes close. For special situations like travel, For example, when women need to go to Africa, one must be getting a lot of patients who want to join their husbands in Africa. And you cannot enter Africa and some parts of South America without taking the yellow fever vaccine. However, you cannot give the yellow fever vaccine in pregnancy because it's a live vaccine. It has a theoretical transmission risk. In this case, women should be advised to avoid or postpone their travel. In case of animal bites, a surprisingly common phenomenon, as I have found in the past few weeks, particularly in public hospitals, the question arises as to whether you can give a rabies vaccine in pregnancy. The answer is quite clearly yes. You can administer rabies vaccine in pregnancy. It is life-saving, and not only the vaccine, you can also give immunoglobulin, because rabies, if it does occur, is lethal. There is nothing, there is no conservative outcome over there. There are, of course, concerns when we talk about universal vaccination for pregnant women. We can talk about the economic burden, but to my mind, the benefits of vaccinating far outweigh the risks of vaccinating. A change in practice, particularly when you switch from the old schedule to the new schedule, as I said, you really have to be quite careful. You have to make sure you give everything in writing, and most importantly, train your staff. You need to counteract the fake news and the links about vaccine-related serious side effects. There are these anti-vaxxers, and I didn't even know that anti-vaxxers existed in India till all the brouhaha about the coronavirus came in. But in the US, there is an entire movement called the anti-vaxxer movement. I simply cannot understand what is going through the minds of those people. And really, we need to be quite strong in advocating and countering that whole narrative. If the patient comes to you for preconception, I've already said, you need to look at MMR or MR and varicella vaccine. Remember to delay the pregnancy. Hepatitis B can, of course, be given. There's no need to delay pregnancy. And if the patient is going to need an HPV, there is no need further to delay the pregnancy. Once the woman goes into the lactating period, you need to make sure that she has caught up with the UIP and consider all these vaccines to make sure that she's fully vaccinated against these problems. So let me now speak a little bit upon, and you can see what I've drawn there. It's the pot of gold at the end of the figurative rainbow, and that is the COVID-19 vaccination. But first, as I said, I am going to speak a little bit about COVID-19 in general. I don't mean to be reductive when I say anything. I'm not diminishing the grief which COVID has caused. But at the same time, I also think that we need to take a step back and realize that things could have been considerably worse. This interview came last year in March 2020. It was all over WhatsApp and Facebook and Twitter and what have you. And there was this gentleman from some American university, and he gave his projections of coronavirus cases. And he said in March 20, he said by July 2020, we will have 3,000 lakh to 5,000 lakh Indians who will get corona, and around 20 lakh Indians will die. And you cannot imagine the amount of panic this created. I literally, was at loggerheads with my society people, bringing all, I stay in a building, and loggerheads with them talking about the rationale. One of the people in my society said, we should spray everybody with bleaching solution when they walk into our building. And, this is the kind of things which cause so much panic, so much irrationality. And, it's like, it reminds me of that upper cartoon where the doctor is saying, nurse, get on the internet, go to surgery.com, scroll down and click on the "Are you totally lost?" icon. And then, of course, there are all the massive graduates of the WhatsApp University who have got their doctorates in medicine from the WhatsApp University, trying to tell us and advise us on how corona spreads and how it doesn't, without realizing that forecasting efforts from epidemics and COVID-19 predictions are extremely difficult. For example, as this person says over here, India is a different country every 200 kilometers. So how can you have one single mathematical model which is going to work across the entire diverse geographies of India, the entire diverse socioeconomic statuses of our country? And, really speaking, these people should have been more responsible. in making predictions, because these predictions led to so many adverse events. I mean, I'm talking about the loggerheads I had with my society people, but that was just a very small thing. It led to migrant immigration and so on and so forth, which was really quite astonishing. And the truth is that India has not done as badly as we thought it would. Now, I'm saying this, and I'm probably going against the grain when I say this. And I don't mean to be political in the very least. But at the same time, I think the efforts which our doctors, our healthcare workers have put in need to be acknowledged. Look at that chart, and this is from unbiased statistical resources. That's from the Worldometer data, and that look at total cases per million population and the deaths per million population. India currently records 160 deaths per million population. The US records 1,778. Brazil records 1,912. People say Indian statistics are never correct. And even if you multiply this figure, the Indian figure, by 5, you will see that we are still not doing very well, as it's illustrated in this graph over here. Let me take you through this very nice representation, and I'd like you to follow the Indian, the Indian worm, and it will give you a very nice illustration of how the pandemic is gone. So that is COVID-19 deaths per million people. And remember, you have to see the metric, and you can see the purple Indian worm going, and you can see that it's quite at the bottom over there. And it goes on and it remains at the bottom till it rises a little bit towards the end of last year, goes down again, and then, remains still relatively quite low. And that's what I meant by saying that I don't mean to be reductive. I don't mean to, diminish or the grief which coronavirus has caused. But at some point in time, I think it has to be accepted that all the efforts of our healthcare workers, doctors, physicians, nurses, and other essential workers have really, to a certain extent, paid off. And that's what the graph looks like on May 8, 2021. Again, this is not from government sources. This data is from what are supposedly unbiased kind of things. The truth is that if you look at all the previous pandemics, all of them have occurred in 2 or more waves. And that is a fact. The whole issue really is whether the wave can be made short and sharp like the second wave has been made. And that's where vaccination comes in. A lot has been said about vaccination, and I would not presume to tell you the very basics of vaccination. But in a sense, how vaccination works is it breaks the chain of transmission. And by breaking the chain of transmission, it reduces the number of cases. When HIV came, we were all so very scared. I remember when we started talking about HIV, I was a medical student and a resident, and it used to be a very scary thing to wash up for an HIV positive cesarean section. The unit which I was in used to do a lot of them because Dr. Kaizad Damane at that time was running this project with NACO and UNICEF. And I used to wash up for a lot of HIV positive patients, and I always used to be very worried. But slowly we have come to an understanding of the HIV virus, and I liken this pandemic to that only in an accelerated time frame. So we don't have a vaccine for the HIV virus yet, but all these technologies which we are talking about today for the coronavirus vaccine were actually developed for the HIV virus, and it is this technology which has come to our stead. It astonishes me. It frankly astonishes me when we talk about comparing the evidence for COVID in the same breath as talking about the evidence, for example, for PIH or diabetes or any other well-known pregnancy disease. COVID has been around for 1.5 years. How in the world can you expect that the evidence of COVID will be as robust as the evidence which exists for all other conditions? It is something like what Albert Sabin, when he invented the polio vaccine, and he said that I've studied the effects of our new lots of polio vaccine in 100 volunteers, and during the next few days shall give it to my wife, 2 children, as well as to our neighbors and their children. And he was applauded at that point in time. Consider this stunning scientific achievement that the coronavirus vaccine is. Look at that table below, which talks about phase 1, phase 2, and phase 3 vaccine trials. And look at the bottom. On an average, before this, it used to take 15 years of research and trials for a vaccine to come to market. And this is fundamentally where coronavirus has changed science for the better. We have managed to isolate the virus and produce a vaccine for it in less than a year. So all the research that used to be done over 15 years has now been compressed into 1 year. Just consider the magnitude of that scientific achievement. For me, it remains one of the most mind-boggling feats of science than one can really think of. So don't take the coronavirus vaccine lightly. It has not really been thrust upon you. There has been a whole lot of studies which have gone out behind both the Covishield and the AstraZeneca virus vaccine, as well as the Covaxin and the Bharat Biotech vaccine. Safety has been proven and it has been approved under the current rules of the government of India. But remember that the journey of a vaccine practically starts when it comes to the market. After that, the journey of a vaccine is fairly complex. The supply chain, if you can think, for a vaccine, for example, the Pfizer and Moderna needs minus 70 degrees of storage or at least minus 25. Consider the logistics of that. Do you think that our country can actually, have that kind of a supply chain? Or do you think we are better off with a vaccine which demands a little more normalized supply chain, 2 to 8 degrees, which anyway we have for our universal immunization program? Let me say this, and I think again, look at the stunning pace of scientific achievement. On the 5th of February, the world crossed the symbolic milestone. The number of COVID-19 vaccinations carried out globally surpassed the total confirmed cases to date. It took 143 days to give the first billion doses. You know that the population of the entire world is somewhere around 7 to 8 billion. And what impresses me the most is the pace of vaccination. Vaccinations, if you look at that graph, we will see that accelerate with every 100 million doses administered. The first 100 million doses took 61 days to be administered, and the last 100 million doses took only 5 days to be administered. Quite clearly, it means that we are getting better at vaccinating. And I really love that sentence. I read it in Bloomberg. 1 billion syringes, 1 billion alcohol-soaked cotton balls, jabs to the skin, and tiny bandages, 1 billion exhalations of relief. It's such a moving and such a touching kind of a quotation. Of course, they went on to say that it will take another 19 months to vaccinate 75% of the world's population. But what they did not emphasize was at the current pace. But we know that with every day, we are vaccinating more and more people. So for example, if you look at this, and this is data I have taken out 27th May 2021, from 18.5 million shots a day, which were administered just 20 days back, we are now administering 29.8 million doses a day. Look at that again, it's such a wonderful feat of humanity. I've heard a lot about India not having enough vaccines. But if you look, and again, this is from Bloomberg data. I mean, you cannot get a more sort of liberal, if I may say so, kind of a data source than that. From all the countries in the world, India has the 4th largest order and reserve of vaccines. There may be supply chain issues now, but rest assured, we will be able to vaccinate our population. We have the 4th largest reserve. And India is a champion at vaccination. And that has been illustrated in the way vaccination is. I know people are very unhappy about vaccination, and I can see that every day on social media. However, again, look at the perspective and look at how it's projected. If you look at the share of people who received at least 1 dose of COVID-19, you will obviously find India at the bottom of the table there. This is what I mean when I say that you have to look at the metric. If you look at share of population, India is at the bottom there. But if you look at the total number of COVID doses administered from December to May. Hey, look at that worm, or the India worm just going up. That's the green worm over there, you can see. And you can see that worm rising. And this is data as recent as May 26th. That's, I think, just a day back. And you will see that in total number of vaccines administered, India is currently only behind the United States of India. So again, I don't mean to be reductive for anybody's problems, but at the same time, I think it is high time to realize the magnificent scientific achievement and the humongous effort that is coronavirus vaccinations in India. I, of course, have taken the vaccine, and I hope all of you have taken it. And this is what I said about selfie. You can see the theory over there of how COVID vaccine works. You have to take a selfie because when you take a selfie, it activates the vaccine. If you don't take a selfie when you're getting vaccinated, your immunity will simply not be there. That was a joke. So Foxy, of course, has been very proactive in the coronavirus time under our dynamic president's leadership. And this is this really excellently well-written statement. And I must congratulate all the contributors, particularly Parikshit, who led the drafting. And it's such a well-written statement on par with any statement which has been issued in the world on the coronavirus. And we use this statement as the basis to write to all the ministries and all the ministers and so on and so forth. We pointed out the fact that there is a paucity of
sir,
data.
You told me to intimate about time. So, 5 minutes to go, sir.
5 minutes? Yes, I'll easily finish, Nilesh. Thank you. We have brought forward the point that at this point in time, there could be concerns regarding transmission of infection to the fetus if a woman is vaccinated in pregnancy with a live attenuated vaccine. However, there are no live attenuated vaccines in the market in India or globally. And therefore, there is no mechanism of such an event. And therefore, by giving COVID-19 vaccine to pregnant women, you're not going to get, have the fetus either exposed to COVID-19 or infected with COVID-19. Data from basic science and animal studies has not shown any teratogenic or adverse fetal or neonatal effects. And that has led all the organizations from all over the world, and you will see FIGO, RCOG, and the ACOG quoted over here, to talk about the fact that ultimately it is the pregnant woman's choice, and she is the best person to decide whether she should be offered and whether she should take the vaccination or not. I really like that meme, when I listen to people saying that, oh no, I'm a little worried about the vaccine, I always post that meme on WhatsApp to them. Because when the vaccine wasn't there, we were all screaming, what do we want? We want the vaccine. When do we want it? As soon as possible. And once the vaccine was ready, we said, oh, that was too fast. We don't trust. It really speaks to me. And I do this. I have saved this in my photos folder on my phone. And every time I get a call saying that, I'm really worried about the vaccine, I send them this meme. I would urge you to find this meme on the internet and save it. It's very effective. So the letter that we wrote, our advocacy tool, was essentially to say that the protection of the coronavirus vaccine should extend to pregnant and lactating women. The very real benefits of vaccinating pregnant and lactating women seem to far outweigh any theoretical and remote risk of vaccination. And we were therefore delighted when the ministry said that, all right, we will allow lactating women to undergo vaccination. And I think we were having a conversation just before this, that it's really not that easy to be an administrator. And I'm not saying that because I'm the Secretary General of Foxy, but that's the truth. Because it's your neck on the line for all the decisions. You say that, all right, everybody wants pregnant women to receive the vaccine, and we go ahead and we give the vaccine, and one bad incident to the pregnant woman can give not only the administrators a bad name, it could give vaccination a bad name. So I don't blame them for being a little cautious, but at the same time, given all the data that is available, given all the evidences that have been presented to them, I would hope that the government of India soon sees the light and allows women who are pregnant to undergo vaccination. And, this caused such a social media upheaval. I really like that saying. For every action, there is an equal and opposite reaction, plus a social media overreaction. It's like Newton's fourth law. for me. In fact, if social media would have been around when Newton was there, he probably wouldn't have discovered gravity because he would have been busy tweeting about the apple that fell on his head under the apple tree. As soon as this statement on the lactation came out, you had this circulars, so-called circulars. There was actually no circular. And newspaper headlines started talking that lactating and pregnant women who give consent can walk in for COVID-19 vaccination. Again, phone calls and all. And then 2 days later, Maharashtra won't defy the national policy on jabs for pregnant women. So let me be very clear, for those who may be listening. As of now, lactating women are allowed to take the COVID vaccine. Pregnant women in India are not allowed to take the COVID vaccine. Even abroad, even in the US, even in the UK, there is no uniform blanket consent for women to take the COVID vaccine. It is that women have to be informed of the risks and the risk-benefit ratio. And then if they choose, they can take the vaccination. And hopefully we will have the government of India towing that line soon. Again, a bit of a perspective, bit of a stepping back. The 1918 influenza vaccine, influenza pandemic infected a third of the world's population. That was the last really big influenza pandemic and killed 50 million people. And there was no vaccination at that time. There was no excellent ICU care at that time. And we live in a time where there is much to worry about, but there is also much to be thankful about. It's a mixture of pragmatism and pessimism because science never really offers a last word. Scientists who believe in absolute certainty must be viewed with a degree of suspicion because becoming enamored with one's own truth defines us as believers rather than scientists participating in the exploration of the continually new. Empathy is important because it shouldn't have to happen to you for it to matter to you. And really speaking, COVID has taught us so many things. The stunning pace of scientific achievement that is possible, bookended by the horrible tragedies which a pandemic which nobody could have really prepared or entailed. But as we start moving back to normal, and I see light at the end of the tunnel, but I hope that is not the light of an oncoming train. And I would like to say this at the end. In the rush to get back to normal, let's use this time very wisely to decide which parts of normal are worth rushing back to. And I can unequivocally say that maternal immunization, COVID and otherwise, are something that we need to preserve. We need to battle. We need to make sure that our women are protected against infectious diseases because as Jeffrey Kluger says, pathogens are mindless but relentless, but science is relentless too. Thank you very much.
Thank you. Thank you, Jaideep sir. I think you gave me a tough task of stopping you in between and telling you the time. And we were just amazed and awestruck to listen to you, such a lucid talk. And I think I am a very small person to comment. We have these stalwarts who can comment. But one thing I would like to say that amidst this COVID times, which is negativity all over, we had such a positive talk on vaccination in pregnancy and that too COVID vaccination in pregnancy. Thank you so much. I invite the chairperson, Preeti Kumar madam, to kindly give her comments.
Thank you, Dr. Nilesh. First and foremost, I would like to thank our dear and sweet Dr. Sunita ji for inviting me to Pune OB-GYN Society. Thank you so much. And Dr. Jaideep, I must say it was an excellent overview of vaccination in pregnancy. And I heard your talk second time, but still there were so many take-homes and so many inputs from this presentation. Thank you so much. And you gave a very good presentation on these vaccination in pregnancy, live vaccines not to be given in pregnancy. The second thing I want to share is just few comments I'll make that most of the public sectors are giving only TD. That's basically because of the cost constraint. Tdap and influenza vaccine is not given in public sector. They are basically opting only TD in the pregnant patients. It's only the public sector, private sector where we are promoting these 3 vaccines. And during this COVID time, it was between 26 to 28 weeks that we tried to give both the vaccines together, that is Tdap and Influvac, right at 26 to 28 weeks when we were calling the patients for checkup. And thank you so much for touching upon the fact that 2 vaccines can be given together, and a beautiful presentation on the statistics of COVID vaccine. That was really eye-opener, and we should definitely feel proud of a country, and lot has been done, and we look forward that wish we could eradicate COVID also as we did smallpox. So thank you so much, Dr. Jaideep, and we wish that the COVID vaccine is available for pregnant women, and Foxy is trying hard, and hopefully we'll get that. Thank you so much.
Thank you, Jaideep. I just can't stop but say one comment. What I loved, see, academics, pregnancy, vaccination, triple vaccinate, third trimester start, and all is fine. What you saw showed the data that India, live data for last 1 year until today, where the India stand. The way world is trying to show India in a negative way, and you absolutely rightly showed we by the positive way. We don't have to be proud that Israel has become mass free because their population is so small. We have given huge number, 3 times more than what they have given. So I really love those 2 slides and those 2 live graphs more than anything, because that shows your character, that shows your personality, that feel pride to be Indian. That's very important. Thank you.
Thank you, Sunita. Thank you, PT.
Thank you. Thank you. Thank you all the chairpersons, and thank you Jaideep sir for this first.
You want to say any comments?
Hello.
Dr. Valera, you want to say any comments before we move?
Actually, he spoke so very well and he presented so well that I have no question left for him. But Sunita, can I ask one question, please?
Of course, sir.
Yeah, I just want to ask Jaideep, suppose if the patient is pregnant 4 to 8 weeks and now she is also found simultaneously corona positive. Because I had a couple of patients in last 2 to 3 months, and then 4 to 8 weeks pregnant and corona positive. So under such circumstances, what we should do? I would like to ask Jaideep.
So, sir, thank you, sir, for that question. The truth of the matter is that there will be essentially 2 categories of patients here. The large number of patients in this kind of a situation, like the large number of COVID patients, will simply be quite asymptomatic and will not require much medical care. In which case, what you really need to worry about is whether the coronavirus is teratogenic or not. And there is really no evidence to show that, in fact, the coronavirus causes teratogenesis. So quite clearly, if the patient is asymptomatic and she is doing well, let her carry on the pregnancy with the supportive care which is required. On the other hand, if you have a pregnant patient who's early in pregnancy and is coronavirus positive and is not doing well, is in the ICU with a very high CT score, etc. Now, that is a situation where you need to consider if terminating the pregnancy will help her come out of the coronavirus problem earlier or not. There is really no evidence to show that that is the case. Terminating such an early pregnancy will probably, in all possibility, not help that patient emerge from the coronavirus infection earlier. It's a different story late in pregnancy, when the respiratory system is in a sense compromised because of the large uterus pressing on the lungs, etc. But in the situation that you are talking about, it's very unlikely that a medical termination of pregnancy will actually help her recover from the corona. So again, over there, I would not really see a place for an MTP, because as we've already established, the coronavirus is not teratogenic. So, it's these 2 subsets of patients and the duration of pregnancy which sort of decides, what your future course of action is going to be.
Right. Actually, these were the patients, who were the cases of infertility and conceived exactly at the same time when they were positive.
Absolutely.
So that's the reason as to why I was interested in asking the question. Thank you very much. Thanks, Jaideep.
Add on here for one important thing. Jaideep, what you say, I absolutely endorse. One important thing for those who are attending, I always like to put on a blood thinner, sir, because with the thromboembolism and missed abortion, I had lost 3 IVF pregnancies at 8 to 9 weeks. They were not immunopositive. but I lost this pregnancy and it is a thromboembolism. So if you detect at 6 to 7 weeks their COVID, even if they are asymptomatic, I will always like to put this patient on LMWH for a while.
Jaideep,
And that's-
if I'm allowed to ask a question to Jaideep.
Sir, please.
Who's
please
going
go
to
ahead.
stop you, Dilip?
Another situation, Jaideep, that we often face in the first trimester is that these patients often are on ivermectin. I mean, these patients come to you, they may have become positive when they just missed the period and they have taken ivermectin. Now, the problem is the drug insert of the pharmaceutical company who's selling ivermectin, they specifically say that ivermectin is contraindicated in pregnancy. Then in such situation, are we then justified? And is it okay to tell them medical termination of pregnancy, or are we justified in telling her, take a chance and continue the pregnancy?
Thank you, Dilip. It's an excellent question. And in fact, I had a similar patient. And that is why I had looked up ivermectin on the internet and all the this thing. You are absolutely right that the product insert says that it should not be consumed in pregnancy. But when you go and look at the literature, and this is available as published literature, it's quite clearly written that ivermectin is teratogenic when it is used in excess of, in 10x, the dose which is recommended for human consumption. So you present this data to the patient and then leave it to the patient to decide. That's what I would say. If the patient decides that no, she does not want to continue the pregnancy, then that's absolutely fine. That's her choice. But if she would like to continue the pregnancy, then there is some reassurance that ivermectin in the dose that we use currently, particularly for the coronavirus infection, is not going to cause teratogenesis. But the problem comes when patient asks you, doctor, 100% sanga sagla barach honar ki nahi. Obviously, you cannot say that. When somebody asks you that question, you have to say that 100% koni sangu shakat nahi, and then let the patient decide.
Right.
Thank you, Dilip sir, for that wonderful question. We have many other questions which are there in the chat box. I think Jaideep sir can answer it in the chat box, but due to shortage of time, we are proceeding ahead with the next talk, and the chairpersons for the next talk are here. So I welcome past President POGS, Dr. Dilip Walke sir, Dr. Kalyan Baramde sir, and Dr. Fessy Lewis sir. So as we all know, Dr. Dilip Walke sir is the past president of POGS and medical legal expert. He is also now pressing on for Dr. Prax, which is the online platform for communication with the patients. Next, we have Dr. Fessy Lewis. He is the vice president of FOXI, and we all know him as a great academician and fertility specialist. We have Dr. Kalyan Baramde with us, who is the chairperson of Public Awareness Committee of FOXI, and he's doing phenomenal work in the field of in this committee, FOXI committee. I'm sorry for that printing which has gone wrong from the Sun team. Sorry for that. I welcome you all, chairpersons.
Feel proud.
One extra committee I got. Thank you.
Okay. So, may I request Dilip sir to kindly introduce our next speaker?
If you can put the slide, I'll be okay.
Yeah.
So there is a lot written in the slide that she's a professor of Mymar College, Pune, fellow maternal and fetal medicine, Singapore, university examiner of UG and PG, and most importantly, she is an international examiner, which I did not know. When I read this biodata, now I've come to know that she is an international examiner for Royal College of Surgeons in London, and there is a lot there in the biodata. But what is not written in the biodata is what I'm going to tell you. That in addition to whatever is mentioned in the slide, I have to tell everyone who's attending here that I call her my niece because she calls me Kaka, and she also treats me like man. But when I say she treats me like a Kaka, I mean she not only takes good care of me, but she also takes the liberty to fight with me whenever it is necessary. And so that she has proved when she was the clinical secretary, and she did a great job as a clinical secretary in 1920, and now she's proving to be a great general secretary. And if you want to know how knowledgeable she is in her subject, you have to listen to her now. And that's what we are all going to do. We are going to listen to her on prebiotics and probiotics. So that's Vaishali for you. Vaishali Kodenak. May I have your presentation?
Thank you so much, sir, for those kind words. Nilesh?
Yeah, you're audible.
Yeah. We can hear you, ma'am. I think
those
you
two
can
questions,
share
as Jaideep said, those two questions you have to ask. That am I audible and is my slide visible?
Yes. So the first question here is, are my slides visible?
No, not yet.
Loading, madam.
It's loading. It's coming.
Kindly stop share and share it again, because you have opened from long. So yeah, now it's visible. Okay.
It came actually. Yes.
Is it there?
Yes.
Okay. Respected chairpersons.
Please make it full screen.
Yes. Respected chairpersons, respected President POGS Dr. Sunita Tandurkar Madam, and respected Secretary General FOXI, Dr. Jaideep Dank. I'm very happy and proud to be here today and giving this presentation on pre and probiotic in vaginal infections. Today is the International Day of Action for Women's Health, where we are supposed to take care of their sexual health, their reproductive health, and also some of their rights. And I really want to congratulate our President Madam for thoughtfully keeping this program today as the celebration of this particular day. Today, again, this is a menstrual hygiene day, which we are celebrating worldwide. And we are going to talk about the probiotics, which can stop or which can prevent infections in genital tract. So today we'll see that the vaginitis, which we commonly treat, but sometimes it frustrates us, or sometimes it really makes the patient also frustrated when it becomes recurrent. And that time we need to know that what more we can do our patient to increase our patient satisfaction. So in short, we will be seeing that what is the flora, protective mechanism, what various infections we get, why there is recurrence in some cases, and what we can do to prevent it, whether it is effective, and how it is effective if the tablets are taken orally. Is it safe during pregnancy, lactation, and otherwise? What are the clinical evidences? Just see this in short run. So we all know that the normal vaginal flora has predominantly lactobacilli, 95%, and other bacteria like Gardnerella vaginatis and Mobilingus, and some H2O2 producing bacteria. They are the natural microbicides. They are also present, and they all, in some small amount, they create or they maintain the vaginal pH and provide protection against infectious bacteria. But when this proportion changes, when the protective bacteria go down and the Gardnerella vaginalis or Mobilingus and Mycoplasma increase in percentage, then definitely there is a problem. So what we see that when there is a shift in the bacterial flora, that the lactobacillus goes down and the pathogens increase, then definitely we have a problem and we call it as vaginitis. And the common organisms are these ones, which the normal common cells, but as the lactobacillus goes down, now they become the pathogens and they start affecting or giving symptoms to our patient. So this is the imbalance between these lactobacilli and pathogen caused the problem. And that may be because of environmental factors or maybe because of external interference like antibiotics for a longer time, poor vaginal hygiene, sexual intercourse with multiple partners, hormone therapy, corticosteroid use. Any of these can cause dysbiosis, and we are going to come to this term that what is dysbiosis in urogenital tract. As we see that normally when the lactobacilli are at highest concentration, with this people having more very minimal concentration, the pH is well maintained. But as lactobacilli go down and these pathogens go on increasing, definitely there is increased pH and also the symptoms of vaginitis creep in. Let's understand what is dysbiosis. First, we will focus on eubiosis, where the normal common cells, that is lactic acid producing lactobacilli, when they are there, the glycogen is broken down from the epithelial cells and there is production of lactic acid, and that maintains the pH less than 4.5. And this pH selects the acid tolerant bacteria only while suppressing the other endogenous bacteria which we don't want to grow. And this maintains a very non-inflammatory environment and also maintains the intactness of the epithelium. The mucus here is viscoelastic, which again acts as a protective one. But when there are other bacteria than the lactobacilli, like Gardnerella vaginalis or Mobiluncus, or the other ones like bacteria, gonococci, even chlamydia, trichomoniasis, all these infections will lead to glycogen breakdown forming acetates, propionates, butyrates, succinates, and these ones, they cause growth of anaerobic bacteria more, which causes leucine breakdown, and there is increased vaginal discharge. Because of presence of amines, this discharge is also having a fishy odor or a mal odor, and that leads to pro-inflammatory environment, and again breach in epithelium is very easily the epithelium can break down. So these are the changes which we call it as dysbiosis, and this has the change environment which is there because of infections. And these infections can be fungal, like Candida albicans or Candida glabrata, or can be bacterial, which we know that common infections. It's not new for gynecologists. It also leads to UTI along with the vaginitis. And these are the risk factors which we commonly see: poor socioeconomic status, to the recent use of antibiotics, pregnancy, uncontrolled diabetes, AIDS, corticosteroid use, which immunosuppression, and now also like we in COVID times we are discussing about black fungus, we are discussing white, yellow, all fungus growth are there, and it's found that in COVID patients, recurrent vaginitis is quite common. So we need to tackle this problem in present situation as well. Let's see the infections one by one. The most common one is bacterial vaginosis, when the lactobacilli, which are to be there as 95%, vanish, and there is white discharge causing Gardnerella vaginitis is specific of vaginal malodor. There is increased vaginal pH and the itching. And the most commonest anaerobe, Gardnerella vaginitis, gives these symptoms. There is this virulent organism causes the vaginal epithelial cells it adhere to, and then it forms the specific diagnostic flu cells and also lead to pore formation in vaginal epithelium. There is replication and biofilm formation. We'll come to this biofilm because understanding this biofilm is very important. It also gives fishy odor, and there is thinning of mucosal layer and increased discharge. Lactobacilli go down. There is attachment of other anaerobic species, and that leads to increased vaginal pH. And this is typical picture of bacterial vaginosis. We treat it, we all treat it, but the common problem which we face is it gets recurrent. 15 to 30% of them report recurrence in 3 months, and 50% of women experience recurrence within 1 year of treatment. And some reasons why this recurrence occurs are like persistence of residual infection, maybe the resistance due to poor adherence, or possibly reinfection by either of the partners. Now, this biofilm, which is the reason for this recurrence, we need to understand that any group of microorganisms where the cells stick to each other on a surface forms a biofilm. In asymptomatic women, it's very thin and sometimes loose, but women with infection have a thick adherent biofilm formed. And the bacteria are there inside this film. And the antibiotic therapy based whatever we give like metronidazole or clindamycin, but it cannot penetrate, cannot reach in this biofilm, and there is no complete eradication even after the complete dose of the drug which we have given. If we sometimes need to give prolonged antibiotic therapy because of the persistent symptoms, again that will harm the healthy vaginal microflora, and thus the problem of recurrence or persistence of symptoms remains. So, in short, this film of the group of microorganisms which are stick to each other, they form the film, and that is that not effectively eliminated by the immune system or fully destroyed by the antibiotics, that tends to persist and it causes relapse and recurrence. And this is the key role which we need to understand or which we need to tackle, that how to control or how to treat this biofilms. Even in vulvovaginal candidiasis, which is the second most common infection after bacterial vaginosis, almost 40% of affected women will have repeated episodes. We also see it very commonly in pregnant women, and most of the times it is Candida albicans which is forming it. Here also the same problem occurs, that there is invasion of epithelial cells, there is modulation of gene expression, and there is hyphae formation. Again, the mature biofilm, which leads to maturation of these cells into hyphal forms. There is increased fungal load, and that leads to all the symptoms. And again, it remains persistent even after treatment sometimes. We all gynecologists are very well versed with the normal pH. The normal epithelial cells with lactobacilli is the picture which we like. But in bacterial vaginosis, there is increased pH, thin white discharge, fishy odor is classical, and flu cells are diagnostic. And this is what we see, that the epithelial cells are glued together with the organisms stuck to it. And in vulvovaginal candidiasis, we have pH lower than 4.5, curdy discharge, which is like cottage cheese, and there are budding hyphae seen on microscopic examination. We know the treatment in the form of metronidazole or clindamycin for bacterial vaginosis, or for the azole treatment, fluconazole for candidiasis. But the persistent one, now the third type of infection is aerobic vaginitis, where the disruption of lactobacilli and the inflammatory changes are more prominent than bacterial vaginosis. And this is caused by group B streptococci, Enterococcus faecalis, E. coli, and Staph aureus. Here the discharge would be greenish, pH would be raised till 6, and more toxic leukocytic and parabasal cells will be seen on microscopic examination. And this also quite rampantly seen in pregnant as well as non-pregnant women. It leads to even UTI, as even the urogenital microflora is unhealthy, and that leads to ascending infection. The colonization of vagina and periurethral area leads to this ascending infection via urethra to bladder and sometimes even to kidneys, and we need to tackle this also. And this again originates with vaginal dysbiosis. Dysbiosis in pregnancy is also very common because of the immunological, endocrinological, and metabolic changes during pregnancy that alters the microflora and makes the patient more prone for infection. It may lead to preterm labor because the abnormal vaginal microflora, ascending infection, bacterial colonization in decidua, which may lead to chorion, amnion, and there will be release of cytokines and chemokines, and that may lead to cervical remodeling as well as uterine contraction and membrane activation, which will put our patient into preterm labor. In infertile women, this is found that the vaginal dysbiosis is very common, and it also leads to adverse reproductive outcome, as well as if the patient is getting treated for infertility, there is poor clinical outcome just because of this dysbiosis, even when the patient is undergoing treatment like IVF. The patient fails to, because what is the disadvantage of our antimicrobial therapy? That almost 10 to 15% of the patients fail to respond, and almost 80%. This figure is so huge that almost 80% have recurrence rate. And what are the causes? That maybe there is emergence of resistant strain, or maybe there is alteration of microflora, or there is persistence of pathogens. So because of this, the recurrence is common, and along with this antimicrobial therapy, we need to have something to be given to our patient to achieve a complete cure. So what we can give, what we think is maintenance of this healthy vaginal flora is of paramount importance. Achieving the normal vaginal flora is the most important thing, and then can we take help of probiotics to achieve this microflora once again. And recurrent infection may also be eliminated by the commensal organisms once the lactobacilli they set in. So we consider probiotics and their role in preventing or completely curing the urogenital infections. Probiotics, Meshnikov has defined long back in 1905 that the live organisms which when administered in adequate amounts confer a health benefit on the host. WHO also agrees with it. And there is also one terminology called as prebiotics. These prebiotics are the food ingredients that appear to stimulate the growth of beneficial bacteria in intestinal tract. And they are fructose oligosaccharides. And symbiotics are a combination of both probiotics and prebiotics. So let's see that can they help us in our problem of having this recurrent infections. So these are the organisms from different bacteria, different species of lactobacillus is the main one. Bifidobacterium is the second most common. Two yeast and molds like Candida, this species is important. These are the ones who are the good bacteria which we want to have. What is their action? These ones, when these lactobacilli are there, what they do is they produce substances like hydrogen peroxide, lactic acid, or bacteriocin, which acts on the pathogen and directly inhibit their growth. That promotes the integrity of the epithelium and there is no breach in host cell. Again, in viral pathogens, it causes co-aggregation based on the cell wall molecule and thus modulate the immune response and thus maintaining the intactness of the epithelium. So in short, how they act? They act by inhibiting the adhesion to the mucous membrane, then production of lactic acid, hydrogen peroxide, and bacteriocin. They maintain the normal flora and avoid infection. It will also be helpful in preterm birth because the chances of bacterial vaginosis will go down and ascending infection will reduce and thus the positive factor can be removed. And this has been proved in few studies which are conducted by Myre et al. That they cause decrease in chances of preterm labor. Even Nordicus conducted a prospective observational cohort study in 37,000 women, and we could find that the chances are reduced to almost by 21%. Even in IVF-like treatment, these probiotics can be of help and improve the results. So let us see the role of prebiotics, which we were talking about along with the probiotics. So these prebiotics, they are non-digestible polysaccharides and they promote growth of beneficial bacteria. And in medicinal plants like onion, chicory, garlic, asparagus, banana, we find these oligosaccharides. And they improve dysbiosis by enhancing growth of bifidobacteria. So along with lactobacillus, we also get the benefit of bifidobacteria here by addition of this prebiotic. Now the question comes to our mind is like we are going to take this prebiotic and probiotic orally, then how it will maintain the intimate sphere or the vaginal sphere or vaginal microflora. So these probiotics taken orally should have resistance to gastric juices once they reach to stomach, to bile, and then they could sustain in the intestine and reach the rectum. There they colonize And from there, the colonies extend to perineum, and then the vagina is what is the theory put forth, and the effects are seen that way, provided the probiotics which you take are resistant to gastric juices, enzymes, and bile. The safety of these probiotics is being proven by different studies. They have not seen to cause any problem even to pregnant and lactating women. Now let's see whether we have any clinical evidences to put or to prove this theory. We have our own POGS recommendation for management of bacterial vaginosis, which is 2018. And it says, along with metronidazole or along with clindamycin cream, probiotics, if taken, mainly the lactobacilli species, and for 15 days, that definitely is recommended for the treatment. We also have one systematic review of almost 14 studies focused on bacterial vaginosis, urinary tract infections, candidiasis, and HPV infection, which proves that the intervention with the help of probiotic was very much effective in preventing the recurrence of candidiasis, vaginosis, UTI, as well as it helped in clearing the HPV lesions. One study, which is published by European Journal of Obstetrics and Gynecology, has also proven it's actually a double-blind, multicentric, placebo-controlled trial where they grouped two groups. One received placebo, one received probiotics, and they have seen that it helps in antibiotic therapy, and there is less recurrence and complete treatment in the group where probiotics are given. Again, this is another study where two groups, one group has received the lactobacilli and the other group has received oral placebo. They have seen that the cure rate was almost 88% in the group where they received metronidazole along with probiotics, and it was only 40% in the group where metronidazole was given along with placebo. After taking the probiotic for 15 days, they have seen the complete cure. Normal flora was found in these women with lactobacilli, and placebo had only 40%. And you should see this, that bacterial vaginosis was found in the group who was treated with placebo, but none of the women who were on probiotics had bacterial vaginosis at the end of the treatment. So these studies are quite promising. So now we can have a capsule or a tablet full of these bacilli who are safe, who can sustain the gastric pH, and along with the prebiotic given once, one capsule twice a day for 15 days will definitely help us in restoring or maintaining normal vaginal flora. This is the percentage. Now the tablet or the capsule should have those organisms which will sustain the gastric juice, and this percentage has to be beneficial or specific so that this would be beneficial to us or to the patient. And this is very important while prescribing the drug, that we see that they could sustain in this gastric juice and intestinal juices. This is a small study again conducted which shows that after taking this dose of for 15 days and the Ansel score was chalked out, and it's been shown that if color of discharge, odor, increase quantity of discharge, and pruritus, these were the symptoms, and the whiff test was done, and it is seen that on day 1 the percentage, and on day 15 the percentage has come down a lot. Even though this is a very small study of only 30 patients, but still the results are quite promising. So in summary, what we discussed today, that the common vaginal infections which we treat commonly, but they have effects like causing preterm labor or even infertility, failure of in vitro fertilization. So giving recurrent antibiotics to them for recurrent infection is not cost effective, as well as it leads to disturbance in the microflora. Also, it leads to antibiotic resistance. So in that case, we need to take help of some other component which will enhance the effect of antimicrobial therapy, and that is considered as the lactobacilli or the probiotics, which will replenish the normal microbes in the vaginal flora. And treating with this lactobacilli, they will provide us bacterocin, which we have seen, like hydrogen peroxide, lactic acid, and acetic acid, and also they will not allow the adherence of the pathogens to vaginal epithelium, and they will restore the altered flora. So with this purpose, we can or we should think of probiotics if given proper strains and in proper quantity, which is stable and can transit through GIT successfully and can change the vaginal flora by causing these effects, then definitely we should take help of these probiotics. And that is all from my side. Thank you so much.
Thank you, ma'am. I think this was again pre and probiotics revisited. Many new points to carry home, take home message. Without taking much time, I would like the chairpersons, Dr. Pessi Lewis and Dr. Kalyan, to make their comments.
I think that was an excellent presentation covering a topic which usually when we go for a whole high-tech latest things, we will be always forgetting, but it is one of the commonest complaints what you see in our practice, which we tend to ignore sometimes or may not give importance when we look into so high-tech things. I think you have covered it very well. I think today we had an excellent speech by two general secretaries, one by Foxy, one from the Pune. And Kalyan, over to you. Kalyan.
Vaishali,
Thank you, ma'am.
can I ask you a question?
Yes, sir.
Yes, yeah.
Yeah. Vaishali, now these probiotics that you said, they were all for all these days were all for oral use. And I used to many a times wonder how an oral probiotic will reach the vagina and the bacterial flora in the vagina will grow. And now there are some vaginal probiotics also. So first of all, are we still going to continue with your oral prebiotics? And what about those vaginal ones? I mean, is there any advantage into using them?
So the vaginal probiotics are also having some role, but it is temporary till you put it. This way, if you are taking orally and then rectal and the perineal flora you completely change, then definitely the chances would be less of having a recurrent infection. So I would say that oral probiotics will be more helpful than the local ones.
One more thing, there are a lot of oral probiotics. Which, how do you rate which is better, or which type of combination will be better? But there is not much studies that each comparing that. All the studies are whether it is effective or not. So, can you have any insight into that?
Yes, thank you for this question. So we basically need to have those typical strains of lactobacillus also and the prebiotics, which will sustain, which will remain, and which will grow. Some of these probiotics need refrigeration, some don't need refrigeration. So we need to select, we need to see that which strains are given in which and what is the quantity. Even the resistance, what they have while transferring through GI tract. Otherwise, till they reach the rectum, the effectiveness may be lost. So we need to see for these things. And as I have shown you the slides, so certain there are papers and they have studied which one are the ones who are more effective than the others. And I have also shown that slide where the pathogens are mentioned. While selecting the probiotic, again, we need to see that whether the refrigeration is required. Because sometimes if you don't, then the strain while taking also, after taking also, the effect won't come if it is not maintained at normal temperature as the vaccine was not useful or less useful if the temperature is not maintained.
Ma'am, there is any role in infertility about these prebiotics, ma'am?
Yes, many of the patients with infertility have been found with this dysbiosis. Like they have an altered flora, and that may be one of the reasons or a contributory factor to infertility. Again, while treating them, if we use this lactobacilli and change the flora, the results of IVF pregnancy or the success rate has increased, and some studies have proven it. The studies are of a small number. Definitely a large, well-planned study is needed, but it shows success with probiotics that the result of even IVF pregnancy will, the success rate will be increased, and take-home baby rate will also increase as they reduce even the preterm birth.
So wonderful talk, Vaishali, and I request the clinical secretary Nilesh to give all difficult topics to Vaishali for the next whole year, so that she makes it easy for us to understand those topics.
There is a president-elect also. He can also follow the same.
Thank you, sir. Thank you so much.
So before I put up my vote of thanks, I would like President-elect Dr. Parag sir to give his comments.
Thank you, Nilesh. It was wonderful listening to Jaideep and Vaishali. Jaideep, you've actually put up our case so well that if you make such a presentation to the government, they should really agree and vaccinate our pregnant women with COVID vaccination, because there are quite a few patients who have suffered, who have died, and we were really helpless because we could not save them. So I think this is something which is so important, and all of us in Foxy have to really put all our efforts together in order to get this. And Vaishali, the topic which you spoke is absolutely theoretical, but you simplified it to the fullest. So very well presented. Thank you.
Thank you, sir.
I was kind of apprehensive presenting it after Jaideep sir. His calmness, his composure, and the way he speaks, and kind of narrating or kind of storytelling, and it's a dialogue. So a lot of apprehension presenting after him, but hopefully I did a kind of okay job. And thank you, sir, for being here tonight. Pune loves you and just keep coming again and again.
Vaishali has indirectly passed on a message, Jaideep. Pune OBGYN Society is with you.
Absolutely. Thank you. Thank you, Sunita. Thank you, Vaishali. Thank you.
Thank you. Thank you, Nilesh.
Thank
You really took it very well. I never can make this program like this. When the company person calls me, I said, look, the only person to be contacted is Nilesh, not me. And really, you did an amazing job, Nilesh.
Thank you, ma'am. I think this POGS Pulse, when it was decided, we decided to include two focus topics with two wonderful speakers, and I am thankful to both of them. We had Secretary General of Foxy and General Secretary of POGS, both of them on one dais, and many things to learn from Jaideep sir. As Vaishali madam said, that his calmness, composure, and to take things ahead in a wonderful fashion. And the extreme positivity in that lecture was what would be the highlight of that lecture. I thank here President POGS for bestowing the responsibility in me to be the convener for this program. I also thank the chairpersons for today, Sunita Madam, Anand Balerao sir, and Preeti Kumar for the first talk, and Dr. Dilip Poake sir, Dr. Faisal Lewis, and Dr. Kalyan Baramde sir for the second talk to be present here. Last but not the least, I would also like to thank all the delegates who have participated till now in a huge number. We had more than 200 to 250 attendance till now, which was a good number. And I would like to thank the academic sponsor Sun Pharma for this event. Hope I am not missed anybody. Thank you so much.
Thank you. Good night. Good night. Thank you, everybody.
Thank you.
Good night.
Bye. Bye, Parag.
Thanks.
Bye.
We can go offline now, Amit.
Yes, sir. Sure.